Okay, so who was able to solve the fall puzzle? You guys did. So what did you do?
Well, you were walking around in your gown. We went over the fall risk bundle. We saw the yellow socks.
So you guys knew I was a high fall risk patient because of my gown and my yellow socks.
Right.
So every shift, and PRN, the nurses are charged with actually using a validated tool called the Poudre Fall Scale to assess the risk of our patients for falls. What's awesome about this scale is it doesn't necessarily take into consideration just the patient's gait. So you guys saw me walking around and I was walking pretty smoothly, right? I wasn't stumbling at all. It takes into consideration so many more factors about our patients. It looks at their history. It looks at the number of medications and the types of medications that they're taking. It looks at their diagnosis. So it's using all of this data in order to assign a score to the patient. And it's either a low fall risk or a high fall risk patient. So when you identify and we put somebody on as a high fall risk patient, we have to implement a bundle. We need to do bed alarm, fall alarm, gate belt,
Door sign.
Yellow socks.
yellow socks, door sign, so we need an identifier outside of that door,
Chair alarm.
gate belt, and
Call light always within reach.
what's most important about that gate belt?
Under the arm. Underneath.
What does a staff member need to be?
Always
Oh,
have to make
fingers
sure you have
under the
a.
back.
Yeah, so you need to be within that arm's reach, and if you're using a gate belt on a person, you really should be hands-on with that gate belt. Adrian noticed that as soon as he put it on, I stumbled, and I could have fallen, but if he would have had his hands on that gate belt, he could have redirected me. So the gate belt, it's not going to prevent every fall. It's used as a tool, though, to help redirect a patient if they start veering off to the side. You can help correct that imbalance. And it also can help if a patient is truly going to go down and you have your hands on that gate belt to safely lower them to the ground so that they don't end up getting some sort of injury. Falls probably are going to happen in our environment, but we want to lessen the injury to our patients. We don't want them to get harmed in our environment. So I've got yellow socks on. Then you identified me as a high fall risk patient. When you see somebody that is walking around with yellow socks and they're not accompanied by a staff member, we need to actually intervene and say, hey, my name is I'm a patient. Hey, I see that you're walking around in the hallway alone. You're going to meet some resistant patients, right? I was pretty resistant to him putting on a gate belt on me. And it's all about our messaging. So if we communicate up front 100% of the time about what our protocols are to ensure the safety for our patients, they're going to hear it from all of us, and they're more likely to comply. We just have to make sure that we're sending that message consistently amongst us all. That starts the moment they hit our rooms. We were going to talk about you're a high fall risk patient. That means I'm going to put this bed alarm on. I prefer you give me a call so that I can come and help you. Otherwise, the bed alarm is going to alarm very loudly and letting us know that you're getting up out of bed. You're going to have yellow non-skid socks on so that you don't slide in the hallways. We don't want you to slide on our surfaces. I'm going to put a gate belt on you when I'm transferring you. We always have to use a gate belt when we're transferring and or ambulating. And when you're using that gate belt, your hands need to be on it. It serves no purpose other than a fashion device at this point. If you're wearing the gate belt, if you have your patient wearing the gate belt, then your hands aren't on it. I'd like to think that we're super fast and can be able to intervene and grab onto our patients, but that's not always going to be the case. Our patients can drop so quickly, and if we're not there to actually catch them, they can cause injury to themselves. And so, always, I'm going to be right there with you. The most awkward conversation is, I'm going to be with you in the bathroom too. And so, we have to have that conversation right up front, though. We're going to be with you in the bathroom. That means, most of our injuries actually occur, fall injuries occur in the bathroom. I'm going to stay with you until your nurse has deemed that you're no longer a high falls risk patient. So if we all 100% send that same message 100% of the time, our patients are going to be like, okay, this is how it is. I mean, I guess I got to do it. Most of the time, they're not going to resist too often. But if you come in and you use the gate belt and you send the message to me 100% of the time, you're always there with me, hands on, you stay in the bathroom even when I have to poop, you come in, you do the exact same thing. Gail comes in and she's got her call lights are going off like crazy and her phone is ringing and she's like, I'm going to just go ahead and sit down, pull that cord when you're done and I'll come in here and help you, and she leaves the bathroom. What's gonna happen when Adrian tries to do the fall interventions and stay with me while I'm in the bathroom?
Oh, they let me stay by myself.
They're gonna throw that in our face. They're gonna be like, well, Gail, just let me stay in here by myself. I'm fine, I didn't fall. That's setting Adrian up and everyone after her for setting you guys up for failure. And so we have to stay consistent 100% of the time. If we have a bundle that we put into place that we're saying that we have to do, we have to implement. Now, you're gonna meet some resistant patients. I can guarantee you, someone's gonna maybe get a little angry. Continue to try to educate. If they continue to get angry, I want you to escalate that up to your nurse. If the nurse can't make headway with the patient, they're gonna escalate it to the charge nurse. And then to the associate nurse manager and the educator, to the manager. We'll even go to the providers and say, you have to come and have a conversation with this patient. We have behavioral health techs that can come and have conversations with our patients to hopefully get them to comply, to understand that we're trying to keep them safe. And it is temporary. It's not like they're gonna be here forever, it's temporary. If they get to the point where they're getting aggressive or that irritated with you, they're making some threats or body language is revealing that you might be at risk, I need you to get out there. So your safety is so important. We don't want you to get struck by an angry patient because you want to stay in the bathroom with them while they're going poop. So steer clear, remove yourself from that situation and call the appropriate authorities. So call, make sure your nurses know, your charge nurse knows, and call security so we can get them on board. It's so important that we send the same message 100% of the time amongst us all, even us nurses, PT, anybody that goes in that room. The moment we give them an inch and we're like, okay, yeah, you know, you pull that cord when you're ready, they're gonna throw that in our face and think that they can keep doing that over and over and over. So safety first, always make sure that we keep our patients safe, stay within that arm's reach, hands on. Then also be thinking about some alternatives that we could be using to keep our patients safe. So if you have a patient that's quickly jumping out of bed, before you can even get to them, they're already out of bed, think about the roll belt that we can use. You can talk with your nurse about implementing that roll belt. Think about if they're sitting in a chair and you're worried they're going to slide down out of the chair, using the, oh my gosh, what is it called? The repositioning.
The new chair system.
Yeah, the seated positioning system. And it basically is designed with the same technology as our TAP system so that they don't slide out. We have things, you can use a posy apron if a patient is really distracted, maybe to get them to focus on the apron so they're not trying to jump out of bed really fast. So just think about those alternatives, escalate it up to your nurse. All right, so this station is the vital signs station. So here you have instructions that say time to take vitals, find correct cuff size, and flip for results. Why are we wanting you guys to find the correct cuff size for our patients when you take their blood pressure? So correct cuff size means accurate data. You guys by far in our patients' rooms, much more than our nurses are. You are the eyes and ears of the nurse, and you're collecting such important data about the patient. If you were to use a too small cuff or a too large cuff, you indeed will get a blood pressure. It's just not going to be the patient's blood pressure. And we're trying to collect data on this particular patient so that we can formulate a plan of care to best take care of our patients. So make sure that you always use the correct cuff size. Know if you start pumping up your cuff and you hear that Velcro kind of give in and it's not gonna keep sticking, and do not do the old-fashioned hand on the cuff until it can take the cuffs or until it can take the blood pressure. Go out and get a new cuff. Do what's best for your patient and capture that accurate data. All right, what else were you supposed to do on this task? It says flip for results. So on here you have some vitals, a systolic blood pressure of 115, diastolic of 75, your heart rate's 88, your SpO2 is 95%. So all of those are pretty normal. Your temperature though is 34.9. Why is that concerning? It's very concerning because it's low. It's a cold temperature. That is not normal for our patients. So early on, what does a cold temperature even mean? What could that indicate is going on with our patient? I think early on, at a very young age, we all know and we all are very well aware of a high temperature. You know, you always have your parents going and touching your forehead and, oh, you're hot, that means you're getting sick, you have an infection. So we know and can correlate a high temperature with infection, but did you know that a low temperature can mean the same thing? It could be a very early symptom of sepsis. And so we want to be looking at our low temperatures just like we would do our high temperatures and report those off to the nurse immediately. Eventually, if you were to document them down, the nurse would see that low temperature, but because it's so abnormal, you want to make sure you verbally translate that information to the nurse so that they can start addressing our patient more promptly as opposed to maybe an hour later when they see those vital signs. So treat it like it's just like a high temperature after you've, and I think it would probably be best if you did get a lower temperature to recheck that data. If they're having a cold wash rag on their head and you take their temperature immediately after you remove that washcloth, you're going to get some ambient temperature transfer, and so you want that head to warm up a little bit before you take their temp. So be thinking about those outside influences that can have an impact on our vital signs. It also instructed you to check out respiratory rates. So here we have a trach patient, and you're going to count the respiratory rate on the patient. The film is for 1 minute long, and what respiratory rate did you guys get? 28. So concerning, is that high, is that low? It's high. So that means our patient is struggling to breathe, their work of breathing has increased because their respiratory rate is pretty rapid. Why do we care about respiratory rates? One, it's a vital that we need to be capturing on our patients. Did you guys know that respiratory rate is the #1 vital sign that could mean that our patient is declining, that they're decompensating, that they're circling the drain, that something is wrong with them? So we need you guys to capture accurate data. Make sure that you are capturing an accurate respiratory rate. And there's a lot of normals out there, so we know that we are going to see 16s and 18s. That's a pretty normal number. But we want to make sure that you guys are very well aware that that number could definitely change the course of action on our plan of care for our patient. So capture it correctly. We don't have a rule here that makes you check your vitals, or that makes you count your respiratory rate for a full minute. We don't have that rule. We do allow you to check for 15 seconds and then multiply by 4, but if there's any doubt in your mind, any question, any concern, I need you to count for that full minute. Make sure that you give us that accurate data. So respiratory rates can be pretty tricky to capture. Once a patient knows that you're looking at them and counting their respiratory rate, they might change the rate that they're breathing. So at nighttime, it's so super simple. You go in the room and you don't wake them up and you count their respirators first. So it's very easy at night, but when you have a awake patient that's aware of what you're doing, you have to be kind of indiscreet on how you're capturing the respiratory rate. So some people will go up to a computer, sign on the computer and say, one moment I'm going to look up some data, and while they're faking on the computer, they're looking at that patient's chest and checking the respiratory rate. Some people are counting as they're getting their equipment on their patient, because the patient's typically not talking. Or some people have said when you have a patient that's pretty chatty, I can get a more accurate blood pressure if you don't chat right now, just for these couple of seconds. That way you can get the most accurate respiratory rate. So get creative on how you're capturing that piece of data. Just know that it's so important. You're the eyes and ears for the nurse, and we rely heavily on the data that you're giving us to influence the plan of care for our patients. Is the eyes and nose. You were charged with calculating intake, as well as what other things did you have to find?
The output from the whole section drain, and also what we have to give for low blood sugar.
Low blood sugar. What else? There's one more thing.
The boost.
The boost. Okay. So eyes and nose are extremely important, you guys. Even more so important when our patients are on strict eyes and nose, which is like ICUs and any of our cardiac patients. We really can cause damage to our patient if we allow them to eat or drink what they want. When a provider orders strict eyes and nose, we need to make sure that we're accurately measuring it. Involve your patient. Ask your patient, what did you have to drink? If you see in the trash there's 5 sodas in there, ask them, did you drink those 5 sodas? That way you can get the accurate information and put it into our chart. When we talk about intake, it's all the liquids that they're taking in. It's like their coffee, their broth that they drink, their water, This one, they didn't drink it, so don't count that one. This one always trips people up. Do you guys all, or have you seen this measuring sign yet in your nourishment rooms? This is a very handy tool that you can use though. You can go and find your volumes if you're unsure of the volumes. Also, please note that like you can use the volumes off of the actual cans or off of the boxes. So just look at those, record the accurate data. So you want to collect all your intakes and you want to document it down in the intake. There is a special place for us to document down the nutritional supplements. Why? Why do you guys think we want to separate this out from all of the other intake?
Those are ordered.
These are ordered. So there is a nutritionist or a provider that recognizes that our patient's not getting enough nutrients, and they've ordered supplements. So we want to try to make sure that we're tracking if the patient is drinking or taking in these supplements or not. How many of you guys, let me show you where it's documented at. Nutritional supplement intake is right below intake, the traditional intake, so make sure you document it there. How many of you guys have seen like 7 or 8 of these lined up in the patient's room? They're not taking in their supplement, right? Do we care about that? We sure do. So we need to know, one, if they drank one, how much did they drink, but even if they didn't drink it, put a 0 there. Your zeros mean just as much as your 237s. We need to know about zeros, and so document down your zeros. That way the nurses, the nutritionists, the providers can all go in there and talk to the patients and find out, why aren't you drinking these? Your body needs this, and we can re-educate about why they should be taking these in. Does that make sense? When we have a hypoglycemic episode, when do we start treating it? When is it considered hypoglycemia? 70. 70 is our number. So if we have a low glucose result, we need to go and treat it. If our patient can take in oral anything, then we're going to give them juice. This juice, we want to account for the volume that they drink. So each one is 125, it's 250. We need to give them 2 juices, and we need to add that as intake, 250. But what we're also asking you guys to do is document down the number of carbs they took in. Each one of these boxes is 15 grams of carbs. And so there's an actual, there's an actual section that talks about oral carbs for hypoglycemia that you can document on. And you would put 30 if they drink both of their boxes. Say they started vomiting after the first box, or they couldn't drink the other one, they went unconscious. Then you would document down that we gave 15 of oral carbs, and the nurse will do the rest for IV. If you guys tell me my patient's blood sugar is 54 and I go in and take the juice to the patient, I'm responsible for documenting that down. But if I say, ooh, can you please go give them juice? I lost a box somewhere. I expect that you document down the volume that they drink as well as the number of carbs. And you can just find that conversion on the actual boxes too. Please know that there's a lot of information that is so important in their intake and output. Oh, I didn't talk about drainage. So this is 65 of JP. I think 65 that came out of this JP. What if it's empty? Do I need to know as a nurse that this is empty?
Yeah.
Document down those zeros. That speaks volumes about this drain. It could be the drain is clogged. It could be that the drain is no longer draining and we can actually pull it out now. That 0 is just as important as the 65. So don't forget your zeros. There's very little. What? Would a graduated cylinder work? Would this even work? You know what I used to use?
Like a 60 cc syringe.
I used to use medicine cups. To get those very small volumes, why not? Use a medicine cup, find out how much is in there, and throw the medicine cup away. We need accurate information, so use the tools that we have around us to use it. As long as your medicine cup was clean and not like the patient's been using them all over them. Just go get a clean one, dump it out, and yeah, you can get a better measurement using those cups. But yeah, there's nothing to say that you cannot use this. Just as long as you throw this away, you don't want to keep it at the bedside forever. You throw it away, get a new one. What did you guys notice that was incorrect about this guy? Your instructions were skin injuries, not on my watch. It's turn team time. Your patient has full consciousness but needs help to turn to her left side. Please ensure all equipment is placed properly. So you guys noticed that she has moon boots on to help elevate her heels, that she has SCDs on, which helps to increase blood circulation and prevent DVTs. She is utilizing the TAPS system, the turn and repositioning system, and she's got wedges underneath her, but they are improperly placed. She's also has a nasal cannula on, so she's needing supplemental oxygen. So one thing, we use a lot of equipment, a lot of supplies in order to take care of our patients. When used correctly, they do a great job. They do exactly what they're supposed to do, is prevent HAPIs, prevent DVTs. They help deliver that supplemental oxygen to provide that extra oxygen. But when we use these incorrectly, we can definitely cause more injury than good. So what we notice with these moon boots is, especially when they are being used with our SCD sleeves, we can cause more harm than good simply because we place these inappropriately. So what you want to always make sure that you take note of is if you have SCD sleeves, that one, the bladder of the actual SCD is underneath the calf of the patient. If it's sitting on top of the patient, you're not going to do anything about DVTs, you're not going to help prevent DVTs. But you're also potentially going to cause harm with this cord that's attached to the SCD sleeve. So one thing we have to make sure when we have a patient that has an order for SCD sleeves is that this cord itself does not come anywhere near the patient's skin. Meaning that this cord should never be resting underneath the heel of our patient. That will cause an injury, a HAPI. If this cord is draped on top of the patient's foot and we put pressure with especially our boots on, you can cause an injury right on top of that bridge of the foot. One of the biggest areas that we can cause injury to is around the ankle, if this is draped off to the side of the ankle. So always make sure that you know exactly where your tubing is coming from and where it's going, and direct it away from your patient's extremity. So, did you guys know that when we use our moon boots, our heel elevation boots, that we actually have an area that you can place the SCD sleeve through? There's two sections, two slits that are inside of the boot that you want to feed your cord through so that it directs it away from the patient's extremity. So make sure you always use these. You don't want to put it through the area where your heel needs to be sitting, because that's where you're going to actually get pressure if you put the tube through there. So make sure it's going through the slits and not the hole. When you put these on, the best way to do it is once you have your SCD fashioned appropriately, before you connect it to your pump, you want to turn your boot inside out so you have gray showing on the outside. You're going to use, let's see if I'm this way, you're going to use your hand through the hole where the heel needs to be sitting as a place for you to grab a hold of the patient's heel. So you gently lift the patient's leg up and you grab their heel and you hold onto it. And then you just need to feed your cord through here and flip your boot upwards. And what's going to happen is your cord is fed appropriately through your slit, and then you also are floating the heel appropriately. It's directly in that hole as opposed to being down further inside of the boot. When you strap these on, you want to strap per color. And so you've got one black strap, one orange strap, and one white strap. So they're color coordinated. You just follow your colors. Black over here goes to black. White goes to white. And orange goes to orange. And that way your boot is sitting appropriately and doing its job by floating the heels and protecting your patient. All right, any questions on DVTs with SCDs and injuries that they can cause? Well, next, what we have is we are using the turn and positioning system to try to help offload the bony prominences on our patient. One of the most common areas that we can get a pressure injury on is your sacrum or your coccyx. And so when you have a patient that can't make those changes in their position, they're at risk for developing HAPI. And what we want to do is utilize our equipment, our supplies, in order to protect this patient. That's why it's so important when we are doing our turns that we're checking for all of the supplies that are on our patient, ensuring that they're not causing any harm. They do a great job if used correctly to protect our patients, but when used incorrectly, they can actually be more dangerous than good. So this poor little guy has her wedges all out of whack. So this one was under her lower legs, then we have this one that's actually serving as a pillow for her. So we need to position these correctly. You also want to make sure when you're turning your patient that you're looking underneath them for any type of foreign objects and you're smoothing out your chucks. So I just happen to know that she's got some keys sitting underneath her. There's a variety of objects that we can find under our patients. I've seen little flush caps, constantly under our patients, the little caps that go on our butterflies. I've seen our patients' phones and menus and crumbles and all kinds of wrinkles. You have no idea what we can find under our patients. These can actually cause injuries to our patients, especially when they're on narcotics, they're maybe not feeling very good, they can't communicate to us that there's something that's really bothering underneath their skin. So we need to be vigilant when we're turning our patients to look under there and smooth out these wrinkles and get it in the best position for them. One of the worst stories that I have is we had a patient that came in, he was altered mental status, he was a neuro patient. Family brought him in because he was completely different from what they're used to with him. He was extremely diaphoretic. We had him on telly because we couldn't figure out what was going on. Had him on telly. Somebody, as he was resting in bed, came and changed his telly battery. The battery itself got left in the bed. And unfortunately, this patient wasn't able to verbalize that he was in any pain or whatever his needs were. He couldn't tell us. And so it was unfortunately found, that battery was underneath his bottom, and it caused a pretty bad burn under there. And so we had to actually go to his family and say, you know, I'm so sorry that your loved one got burned by our battery. Something so simple that we could have prevented. So always want to look underneath your patient to clear the area of any type of foreign objects. So when we use the TAP system, there are certain positions that we need to put this and utilize our wedges on. So this one is the lower extremity portion, or lower extremity wedge. There is a proper placement for if it needs to go up or down. There's messaging on side of the wedge that will tell you which way it goes up or down. But the importance of that is there is some fabric here that interacts with the actual draw sheet, which will prevent your patient from sliding off and causing shearing injuries. So we always want to make sure that we have them facing up appropriately so that we can utilize that technology to prevent the slide. How many times have we actually gone into our patient's room, just turned them an hour ago and they're already out of position. And it's because they just slide right on out of there. And so use this to help prevent those slides. So ideally, this one needs to actually go below the gluteal cleft. And so you want to put the wedge itself below the gluteal cleft and drape these underneath the legs. And so they're going to serve as a pillow and elevation underneath those legs. What happens if we put this directly on a patient's sacrum or on their coccyx, right on their side? Does it do any good for our patient? It doesn't. So what happens is this is no better than the patient sitting on a hard table or on the floor or on a hard surface. We are still causing a lot of pressure in that area. And so we need it to go below the butt cheek, so below that gluteal cleft. The other wedge, so we'll go ahead and put this underneath her. The other wedge needs to go above her hip. Below the gluteal cleft, and then this one needs to go above her hip. And what we're trying to achieve is being able to put our hand underneath the patient's body to palpate their sacrum and their coccyx. The other device that is pretty common with causing injuries is our nasal cannula. And so we use the nasal cannulas in order to help provide supplemental oxygen for our patients, but they can actually become very dangerous. One of the most common places that we can get pressure injuries is directly on top of those ears. And so we are lucky that we have some equipment that comes with these little gray pads, which is designed to place right on top of the patient's ears. It's even more critical to utilize these little gray wet pads when a patient has glasses on. So when you go in there and you do your turns, check to see if they're on oxygen. If they are, then actually lift it up a little bit. Give their ears a breather break. Make sure that these little gray pads are over the ears and not being utilized anywhere else. Now, if you do notice that you've got some redness or areas on the cheeks that you're concerned about, bring that to the nurse's attention, and we'll actually look at some different devices that we can use to protect those cheeks. But these are specifically designed to protect our ears. You also want to make sure that you don't cinch it too tight, because what happens is that just pulls it right into the patient's face. And so don't cinch it too tight to where it's actually feeling like you're choking the patient. And then I do want you to be very mindful of where our cords are being placed. And so an area that we can actually cause injury is right underneath the patient's back. If their cord is draped underneath their shoulder or balled up underneath there, this can cause a pressure injury underneath their skin or on their skin. And so make sure that you have it draped up and away from your patient so that they're not resting on this object, which can cause injuries. we have instructions that say help protect your patient from a CAUTI. A CAUTI is a catheter-associated urinary tract infection. So any patient that has a urinary catheter that's placed inside of their bladder and their body is at risk for developing a urinary tract infection. Just think of the catheter itself that's going up inside of the bladder, going through the urethra to the bladder as like a little ladder that little bacteria can crawl up and flourish inside of the bladder. Not sure if you guys know, but our bladder is the most sterile environment in our body. So when you don't have any good bacteria in there, and you don't have any bad bacteria in there. So when bad bacteria enter, there's no bacteria that can fight it off, and they just flourish. So our goal, our job, is to try to protect this patient from getting little bad bacteria climbing up and then getting inserted into that bladder. So you guys were tasked with trying to protect this patient from developing a CAUTI. You come into your shift, and she is a mess. She's got poop on her leg. She's got poop on her catheter. Where is her catheter at? Upon further inspection, you see her catheter is sitting like right upside of her bladder, right on top of her bladder, on her belly. And where's her cord at? It's draped underneath her, which we know from our happy station that could potentially cause a hospital-acquired pressure injury. So we need to make sure that we know where our catheter is and we don't let our patient lay on top of that. Why is it bad to have our patients' catheter sitting on top of their bladder? It's bad because I said urine is pretty sterile. It's the most sterile environment is our bladder. When it comes out, it's pretty sterile. However, when it's sitting inside a reservoir, bacteria are going to find their way in there. And the moment we have this sitting up and above and mounted on top of the bladder, there's the potential that we can have backflow of that urine back into our patient's bladder. There's also, you're going to have problems with drainage. It's not going to actually drain right. And so you need to always make sure that your catheter is below the bladder, not sitting on top of the bladder. This becomes very important when we're actually transferring our patients from a gurney onto a bed or vice versa. So we always want to make sure that we're aware of our catheter and where it's at. Before you do any transfers, you need to empty out this bag completely so that there is less likelihood of backflow going back into the bladder. And if you guys are wondering what this little guy is, this is actually a clamp that you can utilize. So say you're moving your patient from one surface to the other, you can go ahead and bend your tubing and slide this right on top, and what it will do is it'll clamp it off so no fluid can run past that, and so you're protecting your patient from that backflow. You just have to remember to unclamp it, otherwise your patient's going to be complaining of discomfort because they're not having urine flow. So you want to put this on the, basically below the patient's bladder. Always use the hook that's provided when we when we're putting it and hanging it below our bladder on the bed. If there is no hook, are we allowed to put these on the floor? That really is not our best practice to put these on the floor. We know our floors aren't clean. We know what the stuff that we walk in, and so we want to limit contact with this thing on the floor. So what I would recommend is you get a clean chucks. You can place this on top of that clean chucks until you can find your alternative, because we have a missing hook, a rigged up system so that you can actually hang it from the patient's bed. You don't want to have this sitting on the floor for an extended period of time, and never, ever, ever should it be on the floor without a chucks underneath it. So get creative, make sure that it's hanging as opposed to sitting on the ground. What else do we need to utilize to help protect our patient from a CAUTI? We've got a cleaner, so let's talk about that. She is a mess. She's got poop everywhere. So when we clean her, what do we use to clean? I'm going to set this illegally, like near her bladder. I would say most part CNAs love, and nurses love to go to our Aloe Touch wipes because they're convenient. They're usually sitting right there. It's a little bit easier than grabbing all of the things you need to use when you use the 4-in-1 cleanser. However, it's actually healthier for our patient's skin for us to use warm water and the cleanser to clean them off. Maybe you can do these initially when you need to get a lot of soilage off of the patient, but you always want to follow up with a 4-in-1 cleanser. When we're cleaning and providing peri-care and catheter care, let's talk about that. That's 2 types of care that we need to provide for this patient that has a urinary catheter. The peri-care is all the area around the catheter. It's so important that we clean off this area so that we don't contaminate our catheter. So if I was to clean off all of this soiledness around her thighs, on her butt, change her chucks out, it does absolutely no good if I don't clean the catheter as well. Or vice versa, if I clean this catheter and I get it pristine and I never clean off around her, the sides of her legs or in her peri area, The moment the catheter touches the side of her leg or anywhere, it's going to be recontaminated. So we need to think of this as a two-part system. You need to clean peri area first and foremost. You always do that first, and then you need to clean the catheter. When we clean the catheter, you want to clean the catheter with or first remove any gross soilage like this one with a wipe. And then you want to follow up with our CHG wipes. So this is proven to protect our patients from developing caries because it limits the number of bacteria that are found on the catheter cord. You should only be using, you really only need to use one of these per catheter. We have instructions that we need to make sure that we do not keep these at the bedside. So we need to consider these more like a medication versus just a wipe. So your job is to grab a new set of CHGs. There's usually 2 in here that you don't necessarily need. So once you clean off that catheter the first time, what should we do with these CHG wipes? Like, really, this should go in the trash. We can't keep it at the bedside. We can't wait to use it for the next time she poops. We need to get rid of it. Also, we've already opened it. And so when we've already opened something, there's a potential that some bacteria can get in there and start flourishing. So we don't want to reuse something that could be potentially contaminated. You never want to have these stored and stocked in the bedside. Make sure that you just remove them and you bring them use them and bring them in as needed. In addition, we do have a stat lock that's in place that you definitely want to utilize. So why do we use a stat lock? Does this cause worry to somebody? We can actually damage the urethra if we don't secure this device. So we use stat locks to help prevent that trauma. It can damage a woman or a man equally as much if we don't secure this. And so when you utilize the stat lock, what you do is there's a proper way to place it. And once you get it placed properly, let's see if I can get it to lock. Now, when I move the cord down here, it does a very limited motion up near that catheter. And so it's a little bit more secure for our patient, a lot more comfortable for them. Just take note that there are some patients that we're not going to use a stat lock on. And so the ones that really come to my mind are the burn patients. Maybe they have burns all over their legs, or maybe Stevens-Johnson syndrome. We don't want to put something really sticky on that skin. And so we might use a leg strap instead, or those might be the patients that we don't actually strap down. But I challenge you, if you go into your patient's room and you see them having a catheter and they don't have a stat lock in place, question it. Most likely it was just an oversight from the nurse's part. They probably just forgot to put it on there, but I want you to question it so that we can try to protect our patients as much as possible.